Hi, everyone. My name is Dr. Jennifer Jackson. I'm a registered nurse and assistant professor in the Faculty of Nursing at the University of Calgary. And this video goes over the differences between audits, quality improvement, service evaluation, research. All of these things are useful tools in healthcare, and we use them each at different times. However, there are distinctions between each piece, and they're important to know when you're working clinically, when you're studying research, or if you're working in a role where you're helping to implement one of these, you need to understand the responsibilities that go with each one. So we're going to give an introduction to these concepts in healthcare services today. So I'm going to cover what the difference is between audits, service evaluations, quality improvement, and research studies, and what considerations you need to know for each. So these are all tools to improve healthcare. There are lots of different ways we can try and make things better for us, for our clients, for the people that we work with. It's about finding the right tool for the right time. So you can think of these as analogous to pain medication. We have NSAIDs, we have acetaminophen, we have morphine, we have fentanyl. All of them are valuable when used in the right amount at the right time. So that's a little bit like these different techniques of clinical audits, service evaluations. They're all sort of pain medication, if you will, but you use different ones for different purposes at different times. And you also need to be aware that, your assessment when you give morphine is different than your assessment when you give acetaminophen. Same type of things here. There's different degrees of responsibility that are associated with each one. Also, it's important that you determine what you're doing based on the goal of the project, not on the tools you use. So, for example, any one of these techniques to improve healthcare could all use a survey. Now, the type of surveys would be different. The aim of the surveys would be different, and the responsibility for the people administering the survey would be different. But you can still use a survey for clinical audit and for research study. So you can't make a judgment on what tool is being used based on, or you can't make a judgment on what technique is being used based on the tool. So a survey isn't enough to say, oh yeah, it's a clinical audit. Because at the implementation phase, a lot of these look the same. It's the upstream sort of, why are we doing it? That's where you get the variation and the distinction between the methods. So something to keep in mind. So I'm going to do an overview of each one, and then we'll talk about each one in a little more detail. So research, our goal is to create new knowledge. We are trying to find a new way to provide care, or a better way to implement care, or new understanding of the phenomenon. So we are going into uncharted territory, and we want to create new knowledge. Therefore, research comes with the highest degree of expectation and protection of participants, because the thing we're doing, we don't know if it's going to work. In contrast, the aim of quality improvement is to improve patient care. So the stakes are a bit lower, because we know whatever we're implementing has already been assessed through research, and we know that it works. So there's not the same degree of risk to the people that are involved. Service evaluations look at how well patient care is working in a defined context. So are patients getting pain management that they need, and can we ask them, work with them to see what they need to improve care in this specific setting? A clinical audit, service evaluation is kind of between the organization and the patients, or organization and families as well, but generally the organization and the people. A clinical audit is between the organization and like a national objective standard, usually. So a clinical audit assesses whether, care at St. Thomas Hospital or Foothills Hospital is meeting guidelines that have been put forward by a Department of Health and or, general best practice guides, like, are we meeting what we believe to be the best care we know how to provide at this point? So you can see that these are all slightly different in terms of who is involved, what the focus is, the risk level, and the context. So I'm going to go through each one of these in more detail. So with research, the goal is to create new knowledge. So we are setting off like knowledge astronauts into space to find something nobody's ever found before. So when we do that, there is high risk. So we don't know if the treatment we're going to do is going to work. We don't know if our experiment is going to work. Or we don't know what we're going to find when we're asking people about their experiences. So because of that, this is the highest risk. And when you do a research study, you have to have ethical approval. So that has to be a formal approval from a research ethics board at a university, an institution, probably both. And you need to have a lot of protections in place so that if things don't go the way you plan, people aren't going to be harmed in the process. So research also applies beyond a single setting. So you could do a research study at a hospital, but say these findings may be useful to, facilities across the country. Even if the results are not generalizable, it transcends an individual space. So, you might be looking at the experiences of refugee women, which wouldn't necessarily be generalizable to a whole population, but you could use that knowledge to support refugee women in other places. So this is bigger than a single ward or unit or hospital or health organization, and it's designed to transcend context. Because of that, this takes time and money. So you're not going to generally get out of a research study in under a year. It is a very thorough, in-depth way to answer questions, but it is also a time and resource consuming way to answer questions. So it depends on what you need to do. If you want to improve practice, you might not necessarily need to create new knowledge. There might also already be knowledge available that you can apply rather than having to start from scratch. So if you are doing a research study, you need to make sure, even if you are, collecting blood samples in a hospital, every person who's involved in a research study has responsibilities of stewardship. So you have to make sure ethical approval is in place. You have to make sure that consent is provided. You have to make sure that everything is set up so that there are safeguards to protect patients, that if you find out a treatment isn't working, that the trial is going to stop. If someone becomes distressed during an interview, there's a plan to get them some support. Like, all of those things have to be thought through in advance. So research can give you a really solid answer, but you're going to wait for that answer, and it takes a long time. So in contrast, quality improvement is aiming to improve practice. It is faster and cheaper because it is lower risk, and the potential burden for the people involved, like patients, is also lower. So therefore, you don't need ethical approval because you're not trying to do something that's untested. What you're doing is taking evidence that already exists and applying it in a clinical setting. Quality improvement is context specific, so it applies to, say, Unit 45 at X hospital. It doesn't apply, across borders and that type of thing. Now, quality improvement, that doesn't mean there aren't lessons for other settings, but it is very much context dependent. So to give an example of a quality improvement project I did, and that I was part of, was we wanted to improve the way that nurses were treating hypoglycemia in the hospital where I worked at the time. So we found that nurses weren't following the protocol of give a fast-acting source of glucose and then a longer-acting source of glucose and protein. That wasn't always being followed. And there was also a lot of confusion around what do you do if the patient's NPO, what do you do if the patient is on an insulin drip, all of these kinds of things. So in light of this, we went to a ward, and this picture, these are my colleagues. This isn't an actual patient, but she was playing a patient for the day. We went and we took pictures of, this is the equipment and the cups and the sugar packets and everything you'd see right out of the hospital cupboards. So we went to a ward and we took pictures of exactly, this is what you take out of the fridge. You need 2 cups and you put it in, you know, a little cup like this. And so that might sound a little silly, but we wanted to make it as tactile as possible. So at 3 o'clock in the morning, when somebody is looking for their, you know, so a blood sugar is maybe 2.7 and they're trying to figure out what to do, hopefully they'll think back to that picture and like just do what's in the picture. So it was an aim to try and improve at the point of care, the implementation of the hypoglycemia protocol. So we decided this was not going to be a research study because we already had a lot of research saying how we should treat hypoglycemia. So we weren't coming up with any new methods. Therefore, we stayed in quality improvement. The other thing was that hypoglycemia is very high risk for patients. It can be fatal if untreated, and it's also dangerous because it's quiet. You know, somebody that isn't struggling to breathe when they have hypoglycemia, generally they might look like they're asleep and actually be having an incident of hypoglycemia. So therefore the risk was very high. So we wanted to act fast to make sure that we could strengthen the patient care, and we were applying knowledge that already existed. We were also doing this at our hospital. We weren't doing it, you know, across a large area. This was to improve inpatient care at one facility. So therefore, we did the quality improvement project. We pulled it together in a couple of months. It didn't take a huge amount of time. I took these pictures off an iPad and then, you know, edited them a little bit, put them together, and we posted them on social media. We used a survey to evaluate, and so this is a case where we used a survey to see whether these posts worked, and which could also have happened with the research study, but our aim was different. In the end, we found out that we didn't get an increase in nurses. We asked them a questionnaire about their knowledge about treating hypoglycemia before and after we did this campaign. We didn't get an increase in the knowledge, but there were also limitations in our study, and I think that we maybe did some good. One thing we learned was that our campaign was too long. We did 10 days and we probably should have done 3 or 4. So, you know, there was good learning there from how do we implement quality improvement projects. So this is an example that shows that you can do something locally without the same burden of responsibility that you would have in a research study. It just depends on what the needs are in that context. So in contrast with service evaluation, we're asking between the organization and patients, clients, residents, families, how well are things working for you? What can we improve? So it's aiming to be a very grounded process when you're getting feedback about what can be strengthened. So one of the most famous examples is the friends and family test. Professor Robert at King's College London has kind of, their research has sort of proven the friends and family test isn't worth the paper it's written on. Nevertheless, it's still used quite widely. So that is, how likely are you to recommend coming to this clinic or coming to this family doctor or to your friends and family? So that's the type of question that you might see in a service evaluation. hopefully something that is better evidence-based, but that's the type of questions. So you want to identify strengths and areas for improvement. These can be clinical things, like I asked for pain medication and I had to wait 45 minutes, and we need a faster process for nurses being able to find somebody to co-sign and access the automated cabinet or things like that. It can also relate to other things like I find it really hard to get in and around the clinic because I use mobility devices and the chairs are all over the place and I can't get through. So all of those things impact quality of care, and asking questions about it can look at where are our strengths and also where do we need to make improvements. As a critique of this is also sometimes these can be weaponized within private systems. So you can see where I've seen where they ask people like the percentage of excellence. So how was your care here? Poor, fair, neutral, good, excellent. And whether the manager keeps their job or not is based on the percentage of patients who say excellent. So it's stuff like that. You're not truly evaluating the service. Then it becomes a bit of a numbers game of like prompting people to respond in a certain way, and it can be politically fraught. Now, at a good, untainted level, a service evaluation is a really useful tool that's context dependent. So how do we improve this specific clinic? But just to keep an eye out, sometimes these can, like anything, they can be used for the wrong reasons. So in contrast, a clinical audit is when we compare care in a specific context with an external objective standard. So this might be a national standard, guidelines from Health Canada, NIH, CIHR, NIHR, NICE, whatever acronym organization applies, it could be comparing with those objective standards. So examples are antibiotic stewardship. So we should only be prescribing antibiotics in specific cases, and we should have, this volume of antibiotic prescriptions, because we know that antibiotic resistance is a big concern and we need to be careful about how we're prescribing antibiotics. So you could look and say, okay, nationally, and these are numbers I'm making up, but for sake of illustration, we should be having 20% of our patients are prescribed antibiotics, and we have 35% of our patients are prescribed antibiotics. So we are higher than a national standard. So let's look and see, is this because we have a distinct population here that has higher levels of need for antibiotics, and this is a genuine difference? It's not a lapse in care. Or you might say, you know what, there's not necessarily a need here for this higher level of prescription. Let's do some education with prescribers to say, okay, let's think about what level of prescribing is appropriate. And maybe we change the guidelines for our organization. Maybe we change the pre-printed order sheets. Maybe we do some in-services with prescribers, those types of things. So it is context dependent, and sometimes governments attach funding to these benchmarks. And so clinical audit doesn't establish whether you get funding or not, but it is important to know that that exists within this space. So one example from the UK is that if you don't have patients moved on from the emergency department in a certain number of hours, your organization is fined. So that is a financial incentive to have patients either like make the clinical decisions faster, so either have them admitted to hospital, discharged, or some type of plan of care. Something like that was well intended. There are examples where that type of mechanism has backfired a bit, because then hospitals end up just moving people to pseudo emergency departments to say that they got them out of the emergency department. And, you know, it ends up creating financial penalties for organizations that can't afford financial penalties. So it's not perfect, but you can see that there are examples where it's, you know, they offer, governments or policymakers will offer general recommendations and say, try and meet this benchmark. But there's other times where they will put a little more pressure on. So attaching funding or attaching other things to incentivize that meeting that benchmark for an organization. So a clinical audit exists within that space of finding out, are we meeting best practice guidelines? And this can be really useful because we want to ensure that we're getting equitable care, particularly across an area. So you want to make sure that someone who's getting care in Toronto and somebody who's getting care in Northern Alberta, or somebody who's getting care in London and somebody who's getting care in Northern Scotland, that they are getting the same quality of care. So national guidelines can be useful, and a clinical audit is the way to assess whether or not an organization is meeting those benchmarks. So the main messages are each of these different techniques contributes to healthcare improvement in different ways. I've presented them here as mutually exclusive, just to help us introduce these concepts. In real life, they can cross over. So maybe you're doing a clinical improvement project, but you build a research component into the evaluation. Or you might do a clinical audit, see that, hey, we've got some deficits here, and then do a quality improvement project to try and transform care. So these do mix together, or they overlap in different ways, but I've tried to go through them separately here just so we can be really clear about what each one does. So if you are the person who's going through the charts or administering surveys with patients or whatever it might be, you need to make sure you know which one of these things you are doing, because then you also know what the aims are and what the burden of responsibility for you is, or what the responsibilities of stewardship are. So there are responsibilities that cut across the whole thing. So people need to provide consent in every one of these examples. With a research study, there needs to be more protection in place around that consent, particularly if you're doing an experiment where people might receive like placebo versus a new medication. So everybody has to provide consent, whether they're filling out a questionnaire or participating in a study, but it's looking at, when you're talking about a research context, the responsibilities there are higher because the risk for the people involved is higher. So not to say it's high, but it's higher than when you're doing context-dependent work to improve care. Friendly reminder, you have to judge these individually by their intentions and by the aim, not by the tools that are used, because the tools might be very similar. In fact, they might overlap at different times. And if you are the person who is implementing one of these techniques, you have a responsibility to make sure that you understand what the project's about, there's adequate protection for participants, and that you are able to maintain data securely, have accurate reporting, and that consent is involved for everyone who participates. So that is a quick run through of these different tools that we can use to improve care. And thank you very much.